So I'm Jill, one of the PGY2 PEDS residents. Today we're going to talk about antibiotics and kids that went to the emergency room with suspected community-acquired pneumonia. This article was found in March of 2020 in the Pediatrics journal. And you can find it at AAP. So I have no disclosures at this time. And then here's some objectives for today. So just, looking closely at the article, figuring out how this can be applied to our daily clinic life, and then figuring out what future studies could be helpful for this. So in this article, up at the top here, you can see who the main authors are that are listed. And so I went through the first and the second one. So the first one is Dr. Matthew Lipshaw. He is an attending at the University of Cincinnati in the Pediatric Emergency Department. He completed his fellowship at Cincinnati Children's Hospital in Pediatric Emergency Medicine. And he did his PEDS or general PEDS residency at Yale. So this is his second published article on this topic. He's still new, kind of fresh out of residency. So he has a couple of published articles, but this is the second one on community-acquired pneumonia in kids specifically. The second author listed is Michelle Eckerl. I don't know how you say her last name, but she's the Pediatric Emergency Medicine Fellowship Director at Cincinnati Children's Hospital. She has multiple articles published, and she does have a specific interest in sepsis and acute respiratory illnesses in the pediatric population. She also has a significant global health background and has done a couple of studies in Malawi with pediatric sepsis, and one of those does include community-acquired pneumonia. This research was supported by NIH. They received 2 grants from the NIH Department of Allergy and Infectious Disease specifically, and then the Gerber Foundation also provided them a grant for this. Okay, so why is this article important? And so we kind of talk about how antibiotics are very frequently prescribed for pediatric pneumonia in the outpatient setting, even though we know that usually these are going to be viral in nature. So one of the concerns that they addressed was that there's no true gold standard at this time for diagnosing community-acquired pneumonia. You just kind of go off clinical suspicion, physical exam, and then some may or may not get a chest x-ray, whether that is available in office or not. And so they kind of talk about how physical exam can be completely different and what is more concerning to other physicians than some. So what are your physical exam findings? Do you hear crackles? Do you hear rales? Do you hear bronchi? Are they wheezing? What does the kid look like? And so that is very different in what people consider concerning and at what threshold do they give antibiotics. There have been previous studies that demonstrate low rates of treatment failure. So there's a previous study that was done that talks about where they gave one group of kids amoxicillin and then they gave the other group of kids placebo, and there was very low rate of treatment failures in either one of them. And so it kind of brings up the question of, should we be given antibiotics for suspected CAP in the outpatient setting, or should we just kind of leave it? Let's see, this study does exclude does have lots of exclusions. So kids that are admitted to the hospital for pneumonia are more likely to have a bacterial cause because it does cause a more severe course of illness rather than those that are not actually admitted. And so we kind of think about in the long run of this article and moving forward is if we're giving this unnecessary treatment to kids with pneumonia or suspected pneumonia, then they're going to end up with unnecessary side effects and some may even have adverse drug reactions. And then there's also the concern of if we're treating something that doesn't need to be given antibiotics, are we increasing the antibiotic resistance? So that's kind of why did we do this study. Okay, so where did they do this? So this was completed through Cincinnati Children's Hospital. They're looking at kids that are anywhere from 3 months to 18 years of age. And these kids had to have signs of lower respiratory tract infection. And they had to have a completed chest x-ray. So the suspicion had to be high enough that the physician ordered a chest x-ray. They had to have one or more of the following to be included in this. So a call for sputum production, chest pain, dyspnea or tachypnea, and then abnormal lung findings on physical exam. And then they also had to present to a tertiary care pediatric ED. So that's a pretty specific finding. And so all of these were completed through Cincinnati Children's Hospital, which is a tertiary care center. Moving on, when did we do this? So this was actually published in March of 2020. The previous studies that they used to analyze the data were published in 2017 and 2019. So these are fairly recent studies, and they are applicable to our prior to COVID. Some unusual findings or some other considerations that I've thought about during this was that this is only one institution that is collecting this data. And so it doesn't take into account diversity that's found in other areas. And so Cincinnati is in the, is in North. And so this doesn't take into, Midwest or Southwest diversity population. They did have a very small sample size. So in the beginning, they started out with 1,142 potential kids that met the criteria for this. And then after they went through and kind of eliminated them based on what criteria they were looking for, there was only 337 left. So that's only about 30% of what they actually started out with were in the analysis portion of this. Let's see, how did they do this study? So this is actually a secondary planned analysis from a previous prospective cohort study. So they are taking kids from 2 previous studies and just really taking observational data from their charts and kind of what their outcomes were. So, and these were all completed at Cincinnati Children's. So they took this study of, like we said, 1,100-ish kids that presented to the ED with community-acquired pneumonia or suspected community-acquired pneumonia, who also had a chest x-ray completed at that and were discharged home. They were not admitted to inpatient stay. So they excluded them if they'd been hospitalized in the past 14 days. They excluded them if they had a history of aspiration pneumonia or complex medical conditions. So that includes sickle cell, any kind of immunosuppression, any kind of chronic lung disease, like if you were premature and had some lung issues at birth. And then if you presented to the ED and you were already on antibiotics at that time, they also excluded you. They did include kids with asthma. I thought that was kind of interesting. So that was not an exclusion criteria. So potential issues that I kind of came up with this article is that they consider it like antibiotic use and the outcomes, but they only included the kids that were giving a prescription or given antibiotics in the ED. There was no actual follow-up on whether that prescription was actually filled by the parents. and if the kid actually took the antibiotics and if they took the antibiotics appropriately. So I think that might have some interesting side effects of the analysis that was done. This age group, since it was a relatively small sample size, they ended up with a very young sample group. So they took anywhere from 3 months to 18 years of age, but the actual median age of these kids was 3.4 years. So they had a pretty young age group. And then the small sample size that we talked about. And then 23% of the patients were actually lost to follow-up. They didn't ever answer the follow-up phone call. That was 7 to 15 days after the date of discharge from the ED. And then of that 23%, 75% were from the ones that actually didn't receive antibiotics. So that could very well skew the end result. And so one of the statistical analysis that this article uses that I was not familiar with prior to this is propensity score matching. So it sounds fancy. So this is actually the statistical matching analysis of observational data. And that just means that they're taking all of this data that we are looking at from an observational standpoint and that is equal and takes out some of the covariables that you have to consider. So the one covariable or co-founding issues here that we see is that providers have a very different threshold of when they give antibiotics versus when they don't give antibiotics. This study took into account antibiotics given by attending physicians, resident physicians, and nurse practitioners and PAs that were in that emergency room. So we all have different training and we all have different thresholds at which we would give an antibiotic. And so some of them that are been there a little bit longer may, hold off, whereas some of the residents may not want to miss anything and, go ahead and give antibiotics more quickly than one of the older ones would, or vice versa. It could be completely opposite. So using this propensity score matching, this reduces bias and co-founding variables that may be present in the information that you're trying to analyze. So we started out with 1,100 kids that were potentials for this study. In the end, we used 337, met the criteria for the study that we were trying to do. And then after the propensity score matching, we only had 294 kids left that were used for the actual calculations and data analysis in this article. Does anybody have questions at this point? Okay. So this slide kind of goes over of what were we actually trying to figure out. So they were looking for the primary outcome was treatment failure. So when or how many kids that they gave antibiotics to had treatment failure, which means who returned to the hospital within 30 days of discharge and was actually hospitalized, who returned or on the return call, who had a change of antibiotics within the 30 days of discharge, or did they go see another provider and had a change of antibiotics, or did they complete the antibiotics? And then at the follow-up call, was there any kind of change in antibiotics between the time of discharge and now? And one issue that they did clarify is, or that they mentioned, was that they didn't ask if this antibiotic change was due to their respiratory symptoms. They also had a secondary outcome that they were measuring. So on this return follow-up call between 7 and 15 days after discharge, they also asked the parents quality of life measures. So these were very opinionated, very dependent on the parent, I guess you could say. And so they were asking them, how long did it take for them to return to completely normal activity after the fact? What were their length of symptoms? did they have like a shorter length of symptoms in the kids that had the antibiotics versus those that didn't, is what they were looking for. And then did they have scheduled follow-up care, or did they represent to, an ED elsewhere? So what we did find here is that, let me see, there was no actual difference between the two that they were looking at. So whether the kid was given antibiotics versus whether the kid was not given antibiotics, there was no difference in outcome. How does this kind of go with our day-to-day clinical? There was no association between antibiotics and treatment failure. So of the kids that were given antibiotics, there was no increased treatment failure, and of those that were not given antibiotics, there was no, increased failures. So this makes us think about, should we give antibiotics in the outpatient setting for a kid with CAP? Also, with the secondary measurement, the quality of life measurements, there was no difference in reported like return to activity or length of symptoms. There was no difference in the two groups as well. But what this doesn't, this still kind of leaves us up in the air of that there is no gold standard to determine whether a kid has community-acquired pneumonia or not. And then there's no golden standard of, should you do a viral panel? Should you do, sputum cultures in this, or should you just leave it? So some of the questions that to kind of think about moving forward is that due to the low rates of actual bacteria and due to this study and some that have been done in previous years, should we look for viral and bacterial etiologies of pneumonia in kids, or should we just see if they deteriorate before we give, or clinical deterioration before we give antibiotics? And so clinical deterioration is very rare in those that are treated in the outpatient setting, and most providers, know when a kid looks bad enough, then they need to be admitted to the hospital. So in the end, we still don't have answers for this, but this is a good study to just tell us and add a little bit more information to the fact that there may not be, there's not specific times when you can safely withhold antibiotics, that there's no specific guidelines. So that might be something to think about in the future and come up with to help kind of create a baseline. So working with Dr. Henchel, we kind of came up with this article in early March, so right before COVID hit. And so during COVID times, one of the things that we're looking at now is that there is more viral testing happening in the ED in an outpatient setting than there was previously before COVID. And so all cases are treated at more of a high suspicion at baseline right now. And so I'm not sure how that'll change in the future. And if once COVID hopefully settles down, will we continue doing more of the RVers in the outpatient setting, or will those kind of slack off? Sorry, there's somebody knocking on our door. So here are my references. This, the top one is obviously this article, and then the bottom two are the other articles that Cincinnati Children's had, the two studies that were used in the past to do this article and study. What questions does everybody have? I feel like that was pretty quick, kind of rambled.